Hi, I'm Dr. Chris Lewis. I'm one of the Doctors in Training Chief Educators. Today we are dealing with pharmacology, and today's subject is on quinolones, folic acid antagonists, and urinary tract antiseptics. So let's get started with the fluoroquinolones. The fluoroquinolones are a very commonly used class of antibiotics. They're used both in the inpatient and the outpatient setting. They have a wide clinical application and have relatively low adverse effects and very few drug-drug interactions. So, are these medications important? Well, of course they are. As a primary care physician, I saw these medications on a daily basis. I prescribe them on a daily basis. So you really need to know them because you're going to come into contact with them frequently. So let's talk about mechanism of action. So these drugs, they enter the bacteria by passive diffusion. They come through little porins or holes in the cell membrane. Once inside, they inhibit replication of bacterial DNA by interfering with the action of DNA gyrase, which is also called topoisomerase II. Now, it also inhibits topoisomerase IV as well during bacterial growth and reproduction. You should also know topoisomerases are enzymes that change the configuration or topology of DNA by nicking, doing pass-through, and resealing. They don't actually change the primary sequence of the DNA. They're basically the janitors of DNA. Now, fluoroquinolones will bind to both the enzyme and the DNA. They create this tertiary complex, and they inhibit the resealing process. And this can lead to cell death by the cleavage of the DNA. DNA gyrase is a bacterial-specific target. Cross-resistance with other more commonly used antimicrobial drugs is rare, but this is increasingly the case in drug-resistant organisms. So let's talk about the antimicrobial spectrum. So all of these are bactericidal with a concentration dose-dependent killing. So the more drug you give, the more killing you get. Originally, they were produced to be effective against gram-negative organisms, though we'll talk about their specific spectrum in a little bit. They do work especially on Enterobacter, so the GI bugs. So think of GI bugs when you're thinking of fluoroquinolones. But they also work on Moraxella catarrhalis, Legionella, Mycobacteria, though it doesn't work on Mycobacterium avium. It also will work on chlamydia, but it's not going to work on syphilis. So fluoroquinolones are split into generations on the basis of what bacteria they are effective against, and this is common of a lot of different antibiotics. So there are 4 generations in fluoroquinolones. The first generation will work on gram-negative rods. They're used in uncomplicated UTIs. An example of a first generation of fluoroquinolone is nalidixic acid. Not going to see this drug very often in your clinical career. Second generation, still it's working on gram-negative rods. It's also good for Mycoplasma pneumoniae and chlamydia. And examples of this are ciprofloxacin, also called Cipro, and norfloxacin. And we'll talk more specifically on these medications a little bit later in the lecture. So third generation fluoroquinolones. Now this is where we see a shift in the spectrum of these medications, going from second generation to third generation. So not only do you cover your gram-negative rods, your Mycoplasma pneumoniae and chlamydia, but you're covering gram-positive cocci. So think of it this way. Think of respiratory bugs, things that are found in the respiratory tract, your strep pneumo. And we'll talk about clinical applications of these drugs in a little bit as well. Now the next generation, fourth generation. Now again, this is going to cover gram-positive cocci. This is going to cover gram-positive bacilli. But it's still going to cover your gram-negative rods. It's still going to cover your Mycoplasma pneumoniae and your chlamydia. Now, another important difference is that it covers anaerobics. So anaerobic organisms are susceptible to the fourth generation fluoroquinolones. The example for this generation is moxifloxacin. And again, we'll talk about these in a little bit. So let's talk about the most commonly used fluoroquinolones. First, ciprofloxacin. Now, what generation was that? Second. It is the most frequently used in its class in the United States. It's effective against gram-negative organisms. So again, think of gut flora, think of traveler's diarrhea, think of E. coli. It's used extensively in UTIs. So it's going to get your E. coli, it's going to get your Staph saprophyticus, it's going to get your Proteus mirabilis. It's also good for a lot of skin pathogens, but it's not going to get MRSA. It's not going to get enterococci or pneumococci. It's great for anthrax. In fact, it's the drug of choice for anthrax. Both for treatment and prophylaxis. And it's also used as the drug of choice for Pseudomonas aeruginosa, especially in patients with cystic fibrosis. Another second generation fluoroquinolone is norfloxacin. It's not used near as often as Cipro, but it's also worth knowing. It's effective against both gram-negative and gram-positive organisms in urinary tract infections. It will still get your Pseudomonas aeruginosa. It will treat complicated and uncomplicated UTIs and prostatitis, but it's not effective in systemic infections, and that's good to know. Levofloxacin, again, this is our third generation fluoroquinolone. It's where we see the major shift from going from just a primary gram-negative drug to both a gram-negative and gram-positive drug. So it has this increased gram-positive coverage. The gram-negative coverage is maybe slightly less than it is than with the second generations. It's active against atypical pneumonia, chlamydia, mycoplasma, legionella. It covers, again, very importantly, strep pneumo. So it's going to cover all your respiratory flora. So it's good for sinusitis. It's good for bronchitis. It's good for pneumonia. It's used in treatments for prostatitis secondary to E. coli. It will help you with bacterial STDs, except for syphilis. And now, though previously gonorrhea was susceptible, now with growing resistances, levofloxacin is not recommended for the treatment of gonorrhea. Finally, moxifloxacin, again, fourth generation. And how is fourth generation different from third? Well, it's still going to get your gram-positive, it's still going to get your gram-negative, but the big difference is that it's going to get anaerobes. So remember that one. The other most important thing to learn about the differences between, say, a fourth and a third generation is that moxifloxacin has very poor activity against Pseudomonas. So would you want to use this medication for your cystic fibrosis patients? No, not at all, because cystic fibrosis often will get Pseudomonas aeruginosa infection. Let's talk about the resistance. First, we were pretty optimistic about these brand of medications, but we're already seeing MRSA resistances, Pseudomonas, coag-negative staph, and enterococci even. There's also cross-resistance between the fluoroquinolones. So if you have a bacteria that's resistant to one fluoroquinolone, it's bound to be resistant to other fluoroquinolones. So how do the bacteria fight against our fluoroquinolones? Well, the first one is with altered target. So mutations in the DNA gyrase and topoisomerase 4, making it less affinity to the fluoroquinolones. Decreased accumulation also occurs. So you're going to reduced intracellular concentration of the drug in the bacterial cell itself. So how does this happen? Well, a couple of different ways. One is decreased number of porins. So if you have fewer holes, you just have less ability to get the drug into the cell. And also there's actual energy-dependent efflux system pumps. So something that's actually taking the fluoroquinolone and shooting it out of the cell. Next, let's talk about the pharmacokinetics. So with absorption, only about 35 to 70% of norfloxacin is orally absorbed. Now this is different compared to the other fluoroquinolones. They are absorbed on somewhere of the order of 85 to 90%. So this is an easily absorbed oral medication. Though there are IV preps of ciprofloxacin, levofloxacin, and ofloxacin, which is another third generation fluoroquinolone, and they're used for more serious infections. Things like sucralfate, antacids containing aluminum and magnesium, or supplements containing zinc or iron may cause impaired absorption. So you want to be careful with those products and taking these medications. Fluoroquinolones with the longest half-life, meaning levofloxacin and moxifloxacin, are nice because they can allow once daily dosing. So where do these medications end up? Well, they are bound to plasma proteins. It ranges from about 10 to 40% binding. They distribute well into all tissues and body fluids. Levels are high in bone, in urine, and kidney, prostatic tissue, and the lung. There is some penetration to the CSF, but it's relatively poor, except with ofloxacin, which tends to penetrate more effectively. It can accumulate in macrophages and PMNs, which means it's effective against intracellular organisms such as Legionella. And they're renally excreted. Therefore, you must renally dose this medication. If you have a patient with impaired renal function, then you're going to have to give them a lower dose of these medications. Let's talk about adverse reactions. They're very well tolerated with toxicity similar to nalidixic acid, the original fluoroquinolone. So what do people get? Well, they get gastrointestinal like most drugs. They get nausea, vomiting, and diarrhea. But this still occurs only in about 3 to 6% of patients. You can get some CNS effects, headache, dizziness, lightheadedness. You have to be cautious in epilepsy. Ciprofloxacin tends to interfere with the metabolism of theophylline and may evoke seizures. Phototoxicity, you want to avoid excessive sunlight and apply sunscreens. Those sunscreens may not be effective in completely protecting patients. And if you do see actual phototoxicity, then you do want to stop this medication right away. One interesting side effect that's also very testable is connective tissue problems. So articular cartilage erosion. You want to avoid this in pregnancy, nursing mothers, and children under the age of 18. Children with cystic fibrosis who receive ciprofloxacin chronically have had some problems with articular cartilage erosion. In adults, infrequently, you will see tendon rupture. So if someone is an avid runner, you might want to tell them to take it easy while they're taking their fluoroquinolone. Contraindications, moxifloxacin can prolong the QT interval, so you want to avoid patients with arrhythmias. It's also, again, as we mentioned before, contraindicated in pregnancy. Drug interactions, the first and second generation fluoroquinolones can increase serum levels of theophylline by inhibiting its mechanism of metabolism. The third and fourth generation fluoroquinolones can raise serum warfarin, caffeine, and cyclosporin.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Well, howdy. My name's Kenny. Nice to meet y'all.
Well, howdy, Kenny.
Keep it in your pants, Paula. Kenny, what is the drug of choice for an anthrax infection?
Oh, don't worry. I've had that. It clears up after a few days.
You funny, Paula.
I think the answer that you're looking for is ciprofloxacin.
Oh, yeah, right on, dog. Yeah, that's right. Don't get cocky there, partner. In addition to fluoroquinolones, what drugs are effective against Pseudomonas?
Oh, that's a tough one, dog. Let's see what you got.
You can do this. I believe in you.
Well, I think the answer that you're looking for, extended spectrum penicillins, third generation cephalosporins, cefepime, aztreonam, aminoglycosides, and polymyxins.
Well, you're not as dumb as you seem.
All right, woo!
You, however, are.
You dumb, Paula. She don't even make no sense.
What?
Hi, I'm Dr. Mike McInnes, and let's go over quick review number 1. The first question, what two enzymes do fluoroquinolones inhibit? Well, the first enzyme is DNA gyrase, which is also known as topoisomerase 2, and fluoroquinolones also inhibit topoisomerase 4. Next question, what is the general trend of bacterial coverage of the fluoroquinolones as you increase in generations? So this is similar to the last question. As you increase in generations, you get increasing gram-positive coverage and slightly decreased gram-negative coverage. Now this changes for moxifloxacin, which is a fourth generation drug, which retains very good gram-negative coverage, and it covers the gram-positives, and it also covers the anaerobes, as I mentioned. Moxifloxacin, though, won't cover Pseudomonas. So first and second generations are great for gastrointestinal infections and UTI infections, urinary tract infections, and the third and fourth generations will cover more respiratory flora. Now we commonly will use a third generation drug such as levofloxacin to treat a urinary tract infection, but there's no real benefit of using that over ciprofloxacin, a second generation drug. Next question, a 25-year-old male patient is diagnosed with community-acquired pneumonia. Which fluoroquinolone would be most appropriate? Well, we just said you want to reach for a third generation drug or a fourth generation drug, such as levofloxacin or moxifloxacin. These later generations have good strep pneumo coverage. Next question, a 50-year-old female who's taking ciprofloxacin for an uncomplicated UTI has noticed that she's getting sunburned very easily ever since she started the medication. So what do you advise? Well, you should stop the ciprofloxacin because she's probably having a photosensitivity reaction from the fluoroquinolone, and you replace it with another antibiotic that's not a fluoroquinolone. Next question, why do we not give fluoroquinolones to children under the age of 18 and to pregnant women? Now this is very, very, very important. You never want to give a fluoroquinolone to a child because there's evidence of increased damage and erosion of the articular cartilage. So So you can get problems with the bones with fluoroquinolones, is the way I remember that. Similarly, you want to warn adult patients that there's an increased risk of tendon rupture. Now, I've used tons of fluoroquinolones over my career. I've never seen a patient with an acute tendon rupture, but it is one of those risk factors. It's very rare, and you need to be aware of that. Particularly Achilles tendon rupture seems to be a real problem in patients who have taken fluoroquinolones. Next question, are the fluoroquinolones effective against methicillin-resistant Staph aureus, or MRSA? You need to know this. Although these may have a very broad spectrum, they may, the third, fourth generation fluoroquinolone may cover gram-positives well. They're not going to cover MRSA, so you have to use other drugs for MRSA. And MRSA is a big problem, not only in hospitalized patients, but more and more patients in the community. Next question, in addition to fluoroquinolones, which drugs are effective against Pseudomonas? So you can use a third generation cephalosporin, such as ceftriaxone. You can use a fourth generation cephalosporin, such as cefepime. You can use aztreonam, which is one of the monobactams. You can use an aminoglycoside, such as gentamicin, and you can use polymyxin. So there are lots of drugs that are effective against Pseudomonas, in addition to the third generation fluoroquinolones. So that's the end of the quick review number 1. Let's go back to Dr. Lewis.
All right, let's move on to our next category, and this is the folate antagonist. So in absence of folate, cells can't grow or divide. Enzymes that require folate-derived cofactors are essential for the synthesis of purines and pyrimidines, which are, of course, the precursors of DNA, and other compounds necessary for cell growth and replication. Bacteria, unlike humans, must synthesize their own folate because the cell walls are impermeable to folic acid. So where we humans can just take a folic acid pill, bacteria can't do it. They can't get that folic acid into their cells, so they have to make it themselves. So let's talk about sulfonamides. Sulfonamides, are, though a great drug, are seldom prescribed alone, except in developing countries, and this is mainly due to their cost. Let's move on to the mechanism of action. So sulfonamides are structurally similar to p-aminobenzoic acid, or PABA, P-A-B-A, a chemical that many microorganisms need in folic acid synthesis. So sulfonamides compete with PABA on the enzyme dihydropterate synthetase, subsequently inhibiting the synthesis of bacterial dihydrofolic acid and thereby the formation of its essential cofactor forms, and they are bacteriostatic. So let's talk about their spectrum. They're active against selected enterobacteria in the urinary tract and nocardia. So how do bacteria become resistant to this medication? Well, they can produce an altered dihydropterate synthetase. They can decrease the cellular permeability to sulfa drugs, and they can have an enhanced production of the natural substrate PABA, or the PABA. Pharmacokinetics. Well, administration. Well, they're well absorbed in the small intestine, except sulfasalazine, and this is used primarily for chronic inflammatory bowel disease and doesn't apply here. There are IV sulfonamides, and those are reserved for those who cannot take them orally. They're not used very often topically, except sometimes in burn victims. Silver sulfadiazine can be used to help prevent colonization and sepsis. They're distributed well in the serum. They are bound to serum albumin in the circulation, and the extent of the binding is dependent on the particular agent's pKa. The lower the pKa, the greater the binding. How are they metabolized? Well, they're acetylated primarily in the liver. Now, the product is devoid of any antimicrobial activity, but it does retain a toxic potential to precipitate in neutral or acidic pH. So this can lead to crystalluria, and this can lead to potential damage to the kidney. We'll talk about that in a minute. So excreted, they are renally excreted, and it is found in breast milk. Adverse effects. So we just mentioned crystalluria. So this can lead to nephrotoxicity. It's due to a tubular interstitial nephritis. To prevent this, adequate hydration and alkalization of the urine prevent this becoming a major problem, and it reduces the concentration of the drug and promoting its ionization. Agents like sulfasoxazole and sulfamethoxazole, which is the most commonly used sulfonamide, are more susceptible to urinary pH than the older sulfonamides and are less likely to cause crystalluria. Another adverse reaction is hypersensitivity. So you'll see rashes, angioedema, Stevens-Johnson syndrome, which is also fairly common, and that's seen more often with the longer-acting agents. Those patients that are sensitive to sulfonamide should not be given other sulfa drugs. So what does that include? Well, sulfasalazine, sulfonylureas, thiazide diuretics, acetazolamide, and furosemide. You can also have problems with hemopoietic disturbances. Hemolytic anemia in patients with glucose 6-phosphate dehydrogenase deficiency can occur. You can find granulocytopenia and thrombocytopenia in your patients. Another important thing, and this is a good testable question, is kernicterus. So because sulfa drugs can displace bilirubin from the binding sites on their serum albumin, they can lead to elevated levels of free bilirubin, which can lead to kernicterus. So let's talk about drug interactions. Well, you can have increased hypoglycemia from a transient potentiation of tobutamine. Your anticoagulant effect of warfarin can increase, and the same thing with methotrexate. Most of this is a result from the displacement of those two drugs on their sites from serum albumin. Contraindications: you don't want to give this to newborns, infants less than 2 months, or mothers near term, specifically for the kernicterus problem. You don't want to get with methenamine, which is a drug we'll talk about in a little bit, because sulfonamides condense with formaldehyde. Let's switch gears to trimethoprim. Sometimes you'll see this shortened to just TMP. Let's talk about the mechanism of action. So there's an inhibition of the conversion of dihydrofolic acid by dihydrofolate reductase to the active form of folate, which is tetrahydrofolate. This leads to a decreased availability of tetrahydrofolate coenzymes required for purine, pyrimidine, and amino acid synthesis. Bacterial reductase has stronger affinity for trimethoprim than it does mammalian enzymes, so this accounts for the drug's selective toxicity. Two other drugs that inhibit folate reductase are pyrimethamine, which is used with sulfonamides as an antiparasitic, and methotrexate, which is used to treat diseases with abnormal or rapid cell growth, such as cancer, rheumatoid arthritis, psoriasis, ectopic pregnancy, and lupus. So what's its spectrum? Well, it's similar to sulfamethoxazole, one of the sulfonamides we talked about earlier, but it is 20 to 50-fold more potent than sulfamethoxazole. It's used in the treatment of acute UTIs, bacterial prostatitis, and vaginitis. Resistances. So resistances in gram-negative bacteria due to the presence of an altered dihydrofolate reductase, which leads to a lower affinity for trimethoprim. And then there can also be an overproduction of enzyme that may lead to resistance because of a decrease in drug permeability. Pharmacokinetics. The half-life is similar to sulfamethoxazole. The drug is a weak base, so higher concentrations are achieved in relatively acidic prostatic and vaginal fluids. It penetrates the CSF. It does undergo some O-demethylation, but most is excreted unchanged through the kidney. Adverse effects: it can produce effects of folic acid deficiency, so megaloblastic anemia, leukopenia, granulocytopenia, especially in pregnant patients and those that have poor diets. And these blood disorders can be easily reversed with supplementation of folinic acid. So cotrimoxazole, you'll also see this shortened to TMP-SMX, or branded-wise you'll hear this referred to as Bactrim. So it's a combination of sulfamethoxazole and trimethoprim. It shows a greater efficacy than either alone, and it's paired because it has a similar drug half-life. So the mechanism of action we've basically already gone over. It's a synergy of both products. So sulfamethoxazole inhibits incorporation of PABA into dihydrofolic acid precursors, and the trimethoprim prevents reduction of dihydrofolate to tetrahydrofolate. So it's a little bit broader spectrum than either drug alone. It's effective in treating UTIs, some respiratory tract infections. One very specific use that you should know for testing is Pneumocystis jirovecii. It used to be called Pneumocystis carinii, so PCP pneumonia is what we used to call it. And now it's this Pneumocystis jirovecii. It's also can be used for ampicillin or chloramphenicol resistant systemic salmonella infections. Resistance, so it's less frequent than either alone, obviously, and a bacteria would have to have resistances to both types of drugs to be resistant, but it's happening more and more frequently. Pharmacokinetics, so trimethoprim is more lipophilic than sulfamethoxazole and has a greater volume of distribution. The administration of 1 part trimethoprim to 5 parts sulfamethoxazole produces a ratio of the drugs in the plasma about 1 to 20, and that seems to be optimal for antibiotic effect. Generally orally administered, except there's an IV form for the Pneumocystis jirovecii for patients who cannot take the medicine orally. Both agents distribute evenly throughout the body. Trimethoprim concentrates in relatively acidic prostatic and vaginal fluids, and both drugs are excreted in the urine. Adverse effects, we talked about some of this already, but to add on, dermatologic problems, very common, especially severe in the elderly, gastrointestinal, nausea, vomiting, glossitis, stomatitis. So hematologic, you can find megaloblastic anemia, leukopenia, thrombocytopenia, but all of these effects can be reversed by the concurrent use of folic acid. So let's review. Why wouldn't folic acid help the bacteria as well? Well, as you recall earlier, bacteria can't bring in that folic acid through their membrane, so they have to produce everything intracellularly. Hemolytic anemia can also occur in patients with glucose-6 phosphate dehydrogenase deficiency, especially because of the sulfamethoxazole. Patients infected with human immunodeficiency virus, HIV, frequently can have fever, rashes, diarrhea, and pancytopenia. Drug interactions, you can have prolonged prothrombin times with your warfarin, especially because of trimethoprim. The half-life of phenytoin may be increased due to the inhibition of its metabolism. And again, as we mentioned before, methotrexate levels may rise due to the displacement from albumin binding sites by the sulfamethoxazole. So our last section is on urinary tract antiseptics. So the previous classifications of medications certainly can be used for UTIs, and they're often used for UTIs. Now, there are a couple of medications we want to talk about that are used only for UTIs. They have no other use at all. So let's review real quickly urinary tract infections. So urinary tract infections include uncomplicated cystitis, pyelonephritis, most common in women of childbearing age and the elderly, and it's a very common diagnosis for primary care physicians. The type of bacteria you're going to deal with, E. coli, is the most common by far. 80% of UTIs are due to E. coli, followed by Staphylococcus saprophyticus, Klebsiella pneumoniae, and Proteus mirabilis. You can treat with these antiseptics, and the two we're going to talk about today are methenamine and nitrofurantoin. They do not achieve antibacterial levels in circulation. They are only concentrated in the urine. So let's talk about methenamine. Its mechanism of action is that it has to decompose at an acidic pH of 5.5 or less, and this happens in the urine. So this produces formaldehyde, which is toxic to most bacteria. The reaction is slow. It requires about 3 hours to reach about a 90% decomposition. It's not to be used in patients with indwelling catheters. Bacteria, luckily though, don't develop a resistance to formaldehyde. Frequently, it's formulated with a weak acid like mandelic acid or hippuric acid. So what's its spectrum? It's primarily used for a chronic suppressive therapy. When someone has chronic UTIs that's needing antibiotics on a regular basis, we'll use this medication just as a preventative prophylaxis medicine. Urea-splitting bacteria that alkalize urine, like Proteus, are usually resistant because if you can't get to the right pH, this medication won't produce the formaldehyde. And it's not effective for upper UTIs. Pharmacokinetics, it's administered orally. Ammonium ion is produced in the bladder. The liver rapidly metabolizes ammonia to form urea. So methenamine is contraindicated with patients with hepatic insufficiency. And because elevated levels of that circulating ammonium ions could potentially be toxic to the CNS. It's distributed throughout the body fluids, but again, there's no decomposition of drugs at a pH of 7.4, which is the usual serum pH, so there's no systemic toxicity, and of course it's excreted in the urine. Adverse effects, at low doses you can get some GI distress. At higher doses you can get some albuminuria, hematuria, rashes. Specifically, methenamine mandolate, which is the combo drug, is contraindicated in patients with renal insufficiency because that mandelic acid may precipitate. And sulfonamides should not be used in conjunction because that formaldehyde can cause the sulfonamides to condense. The last medication is called nitrofurantoin. It's less commonly employed for UTIs because of its narrow antimicrobial spectrum and toxicity. Sensitive bacteria reduce the drug to an active agent that inhibits various enzymes and damages bacterial DNA. Antibiotic activity is greater in the acidic urine. It is bacterial static. It's useful against E. coli, but some of the other more common urinary tract gram-negative bacteria may be resistant, so we don't use it very often for that. It can still get some of the gram-positive cocci. Its adverse effects include GI disturbances, acute pneumonitis, and neurological problems. Sometimes you will see this medication used in pregnant patients. It does have a favorable pregnancy category.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Gesundheit! Oof! My apologies. Spring is in the air, which means I have the hay fever. I have mastered the mysteries of the cosmos, but I cannot seem to master my allergies. Anyway, with all this talk of sulfur this and sulfur that, I thought we should review the drugs to avoid in patients with sulfur allergy. First, the obvious ones. Sulfonamides, sulfasalazine, and sulfonylureas. Also, lots of diuretics, loop diuretics, thiazide diuretics, and carbonic anhydrase inhibitors. Achoo! Gesundheit! Und finally, probenecid, sumatriptan, und celecoxib. Ach, mein Lieber! This hay fever will be the end of me. This is worse than the time I called it disco fever. At least with that I got to wear platform shoes.
All right, let's go over quick review number 2. Number 1, why must bacteria synthesize their own folate? Well, bacterial membranes are impermeable to folate. So sulfonamides are targeting the folate production mechanism inside the bacterial cells. And that's why these drugs are not going to affect human cells, because our cell membranes are permeable to folate. We can just take in folate. We don't have to make our own. Next question. Sulfonamides are structurally similar to what substrate which is needed for folic acid synthesis? Sulfonamides are structurally similar to PABA, P-A-B-A, which stands for p-aminobenzoic acid. You need to be aware of that. That's a very common board question. You need to understand how these drugs work. Next question. What is the clinical use of sulfur sulfadiazine? The brand name of this is Silvadene, and it comes as an ointment that you put on topically on bird wounds to prevent bacterial colonization. So you just smear this stuff on it, and it's this white, creamy, gooey, greasy, awful ointment. It comes in a big tub. You smear it on the wound, on the burn wound, and you put a bandage on that to keep it from getting onto the clothing and everything else. Next question, why shouldn't mothers near term or neonates or infants less than 2 months of age use sulfonamides? Sulfonamides will increase the risk of kernicterus. So that's hyperbilirubinemia that causes some brain problems, some CNS problems. So you want to avoid this in neonates, infants less than 2 months of age, and in women who are pregnant and near term. Next question, what is the mechanism of action of trimethoprim? Well, trimethoprim inhibits the dihydrofolate reductase enzyme. So again, it acts on folate synthesis in the bacteria, but in a slightly different way than the sulfonamides do. Next question, an AIDS patient with a CD4 count of 100 presents with diffuse bilateral interstitial pneumonia. This is not good. What is the probable diagnosis and treatment? Well, the most likely diagnosis in this patient with diffuse bilateral interstitial pneumonia is pneumocystis jirovecii, or PCP, pneumocystis pneumonia. And you're going to treat this with trimethoprim sulfamethoxazole. Now, follow-up question, at what CD4 count would you usually want to start this drug, this trimethoprim sulfamethoxazole combination, as a prophylaxis to prevent PCP? Well, when a patient gets a CD4 count of 200 or below, you start the drug as pneumocystis prophylaxis. Next question, why doesn't methenamine treat systemic infections? Remember, methenamine requires a low pH of 5.5 in order to be able to decompose to formaldehyde, and that's how methenamine works. It decomposes to formaldehyde and then kills the bacteria. And you can only get that low pH in the urine, so it won't work systemically. Next, name the 4 most common bacteria that cause UTIs. So far and away the most common is E. coli. But you can also get urinary tract infections from Staphylococcus saprophyticus, Klebsiella pneumoniae, and Proteus mirabilis. And I'll give you one clinical pearl. Proteus mirabilis will also cause more alkaline urine infection. So if you get a urinalysis back and it looks like they've got an infection, and lo and behold, their pH is high, it's 8, this is most likely a Proteus infection. The next question, which bacteria is notorious for causing staghorn calculi? Well, this is Proteus mirabilis. So that's the end of the quick review. Now's a good time to pause the video and complete the end of session quiz, and then we'll go over all of these answers. So let's go over the answers to the end of session quiz. The first question, match the following fluoroquinolones to the appropriate characteristic. So ciprofloxacin is the most frequently used fluoroquinolone in the U.S. Levofloxacin has a wide therapeutic range, and it's a third-generation fluoroquinolone. And then moxifloxacin is not effective against Pseudomonas infections. Remember, this is a fourth-generation fluoroquinolone. It's not effective against Pseudomonas. Next question, what's the mechanism of action of the quinolones? Well, these drugs passively diffuse into the bacteria through porins, and then they interfere with two enzymes. They interfere with DNA gyrase, which is topoisomerase 2, and they also interfere with topoisomerase 4 during bacterial growth and reproduction. Next question, match the fluoroquinolone generation with its bacterial coverage. Again, we've already covered this a couple of times, but it's really important, it's really clinically useful. So first-generation fluoroquinolones are very rarely used, but they can be used for gram-negative rods and uncomplicated UTIs. Second-generation drugs will still cover the gram-negative rods. They'll cover mycoplasma and also Bacillus anthracis. Third-generation drugs cover the gram-negatives a little bit less well than the second generations, but they will also begin to cover gram-positives. And the fourth-generation drugs will cover the gram-negatives very well. They cover the gram-positives well, and they also cover anaerobe. Next question, name the common adverse effects from the following drugs or classes. So fluoroquinolones will cause GI disturbance. They can cause some lightheadedness. They can cause phototoxicity. They can cause erosions in articular cartilage, which is why we don't use them in who? Children and pregnant women. They can cause tendon rupture. And like a lot of drugs, fluoroquinolones can prolong the QT interval, and that can predispose to cardiac arrhythmias. Next one is sulfonamides. Sulfonamides can commonly cause crystalluria. They can cause hypersensitivity. Lots of patients are allergic to sulfa drugs. You can get hemolytic anemia. You can get kernicterus in newborns. You can also have a lot of drug interactions. And then trimethoprim will possibly cause megaloblastic anemia, leukopenia, and granulocytopenia. Next question. Match the following bugs, bacteria, with the most ideal drug or the alternative. So for Bacillus anthracis, we already mentioned a second-generation cephalosporin. We typically use ciprofloxacin. The next one, strep pneumoniae, you would use a third or fourth-generation fluoroquinolone such as levofloxacin or moxifloxacin. This is why we don't use ciprofloxacin, a second-generation drug, to treat pneumonia. We use a higher-generation drug. And then pneumocystis jirovecii, you want to use trimethoprim, sulfamethoxazole for that. Next one, match the following medications with their mechanism of action. So methenamine is going to break down into formaldehyde, and that's going to kill the bacteria. Trimethoprim sulfamethoxazole is going to inhibit dihydrofolate reductase and otherwise inhibit folic acid synthesis. And then ciprofloxacin inhibits bacterial topoisomerase 4 and also DNA gyrase or topoisomerase 2. This is the mechanism of action of fluoroquinolones. Next question. Why wouldn't you use ciprofloxacin for community-acquired pneumonia? Well, ciprofloxacin does not cover gram-positive cocci, as we mentioned. Strep pneumo is a very common pathogen that causes pneumonia, so you need to use that third or fourth generation fluoroquinolone. Next question. What are the clinical uses for TMP-SMX, trimethoprim sulfamethoxazole? Well, it's very commonly used for urinary tract infections. It's used for respiratory tract infections sometimes. It's used, as we mentioned a couple of times, for pneumocystis jirovecii pneumonia, or PCP. It can be used for salmonella infections that are resistant to ampicillin or chloramphenicol. It can also be used for MRSA, or methicillin-resistant Staph aureus. Now, we already said that fluoroquinolones don't cover MRSA, and there are a very limited number of drugs that will cover MRSA. Vancomycin, often rifampin, and trimethoprim sulfamethoxazole. So if you have a patient who comes in with a cellulitis, you think this is most likely a staph infection, you got to be thinking it could be methicillin resistant. It might be a couple of days before you get sensitivities back if you're able to get a culture. So you want to treat with something that's going to cover MRSA. Next question. Which drug should be avoided in a sulfa-allergic patient? There's lots of drugs that cause sulfa allergies. So obviously sulfonamides do. Celecoxib, which is a COX-2 inhibitor that's used for osteoarthritis and acute pain and acute inflammation, so celecoxib. Furosemide, which is a loop diuretic, which also happens to have a sulfa moiety. Thiazide diuretics, such as hydrochlorothiazide, can also cause sulfa allergy in patients who are sensitive. Probenecid, which is a drug used for gout. Sulfasalazine, there's a hint there. Sulfasalazine is a problem with patients who are allergic to sulfa drugs. This is an anti-inflammatory that's used for inflammatory bowel disease. Sulfonylureas, again, sulfonylureas. These are drugs used to treat type 2 diabetes. Sumatriptan, which is used to treat migraines. And acetazolamide, which is another diuretic. It's a carbonic anhydrase inhibitor, and it's often used for glaucoma. So all these drugs can cause sulfa allergies, and you should avoid them in patients who have a known sulfa allergy. And finally, how do the sulfonamides cause kernicterus? Sulfonamides displace bilirubin from its binding site on albumin, and that can lead to increased hyperbilirubinemia, increased bilirubin levels, and lead to kernicterus. So that's the end of the end of session quiz.